Hi, everybody. Today we're going to be talking about immigration-informed emergency care. My name is Shamsher Samra, based at Harbor UCLA. I also work in the jail system here. We're going to have a group of speakers here, and I'll allow them all to present themselves as their sections come up. We're all based in LA, but hopefully we can provide some lessons and some experience that can inform your practice when it comes to caring for individuals who are undocumented. So the objectives for today's presentation are to really understand what are some of the structural determinants of immigration and health. Basically, like what are the conditions that are driving migration and driving inequities in the health of migrant, immigrant, and undocumented populations. We're going to provide a policy update on immigration-related policies, as well as provide an overview of some of the health impacts of immigration, undocumented status, and the idea of immigration as a social determinant of health. Then we're going to go past some of the background here and outline some framework of pragmatic solidarity, meaning what are interventions we could be taking in our day-to-day practice in the emergency department and our hospitals to be practicing immigration-informed care. And lastly, we're going to introduce this idea of liberatory solidarity. Essentially, how do we combine the work that we do day to day in clinics and emergency departments and hospitals with the work that needs to be done to undo the structures that promote inequity in the health of undocumented patients. So I want to start off with just a broad overview of the demographics, and people may be familiar with this. Any given year, there's about 10 to about 12 million undocumented individuals. The data is limited for obvious reasons. The general trend is the number of individuals has decreased over the last decade or so, as you can see on the chart on the left. And you can see that individuals who are undocumented live throughout the United States, essentially. So while we kind of think of border states and the South, California, some states in the Northeast is where a lot of this population may reside. It's actually something that is relevant to the practice of emergency medicine providers throughout the country. And as we'll talk about later, given the barriers to accessing care, it's really emergency departments that are the entryway to our healthcare system for many individuals who are undocumented. So I think regardless of people's expertise in this area or focus on immigrant healthcare, it's something that's been very talked about in the news and the media. And I think regardless of people's political positioning, it's really been framed, at least in recent years, as a crisis. Whether people view it as a crisis of people who are invading our country, or it's framed as a humanitarian crisis relating to caravans of people coming from Central America, or the separation of families due to our immigration policy here in the United States. And I don't want to diminish the human impact and toll of these recent events or the urgency of acting, but I wanted to provide a little bit of context to what's happening currently. And these charts here outline some trends over the last couple of decades, and you can see apprehensions at the US-Mexico border over the last 20 years or so. While there was definitely a big uptick in the last year, you can see the overall trend here. And again, this isn't to diminish the fact that border policies have been constructed, and this has been demonstrated in a way that knowingly creates death and suffering, intended to disincentivize people and drive people to more dangerous routes in crossing the border. But it's just to highlight, this history, that this isn't a contemporary, very recent crisis. And similarly, deportations, we see kind of the trajectory over the last couple of decades. The border patrol ICE apparatus is not something that's new. It changes and it shifts, but it's something that it's infrastructure that's been in place and is going to outlast the current crisis moment, in quotes. And the reason I highlight that is that all of the attention to the crisis and what's happening at the border has the potential to distract us from the broader structural factors that really force people to move. Globally, 1% of the entire world's population or more is thought to be displaced at any given moment, and it's related to issues of global warming, economic issues, political issues, and in relationship between the United States and Central America has a lot to do with histories of intervention, whether it's military or economic. And the downfalls of not recognizing these issues comes up in papers like this. And this isn't to knock the American Academy of Pediatrics. I think this is a great paper talking about detention of children at the border and family separation. But you can see this quote here: unprecedented violence, abject poverty, and lack of state protections of children and families in Central America are driving an escalation of migration to the United States from Guatemala, Honduras, and El Salvador. And I'm not here to say that this is a false statement. There is violence, there is poverty, and there is issues with state institutions in these countries. But the problem is it twofold. One, it kind of creates a case of charity. Creates a situation of worthiness in the sense that these are people worthy of our charity because they're fleeing this oppression. And then the second thing, it glosses over the role of the United States, other countries in basically promoting or driving people to leave their countries. And it unintentionally or intentionally creates some level of racism towards countries where there's predominantly Black and brown people and instability in the global South. So all that to say, we need to have a recognition of structural violence, that these border walls exist. There is suffering at the border walls themselves, but a lot more goes into creating the separation and maintaining these gross inequities in wealth. And we have to recognize what those forces are, because they're not strictly historic, they're ongoing in this contemporary moment. And so that's basically a call out to have some level of structural competence, to understand the relationship of our country and our power structures with the countries from which people are arriving. And to take El Salvador as an example, there's many examples, but a decade-long civil war where the United States actively promoted and funded military interventions, followed by policies like NAFTA and CAFTA, which essentially promote businesses that extract wealth and export of wealth from countries in Mexico and Central America, rather than promoting autonomy and democracy in those countries. So in those ways, we're complicit in migration and the lives of the folks that we're trying to serve. And the last thing I'll mention is that with this structural competence lens, it allows us to move away from humanitarianism to ideas of solidarity, of working with individuals, ideas of charity, where we're going to give something to the worthy immigrant, to agency, and recognizing the fact that people are agents of change in their own capacity, and we should promote that. And lastly, we move from our individual and local interventions, particularly in healthcare spaces, to thinking about how do we work in collective and global spaces if we really want to promote true equity. And with that, I'll hand it over to Todd.
Can you see my slides?
Yep.
Yes. Good. All right. So I'm going to talk a little bit about causes of migration, specifically focusing on recent changes and kind of current policies that are impeding the health of migrants. And an important quote from Warsan Shire, who's a Somali poet, that always kind of guides this subject matter, is no one leaves home unless home is the mouth of a shark. And it's important for us to understand that the migration that has been publicized more in the last 4 years, especially from Central America and Northern Triangle, has represented a shift in reasons for migration. And some of the work done by David Eisenman at UCLA has documented how, although historically we've always thought of people as migrating for economic means, for jobs, instead this latest migration has represented a much larger proportion of people fleeing because of violence, political violence, persecution, and overall victimization in their home country. So one of the important things that we're trying to understand here is that, the instability and vulnerability that causes migration. Some of this, in the past has had to do with destabilization by nations and destabilization of entire regions of of especially Central South America, due to global, often economic policies. NAFTA being one of them that was especially provided an impetus for people to migrate for jobs. But as we're seeing more recently, people are shifting, and there's a lot less economic migration, but instead forces on the local scale and largely in country that have to do with syndicated crime and corrupt, absent governments, in the translocation of gang groups from the U.S. actually into Central America has caused a lot of persecution and just ongoing violence. One of the other important things to understand is that our policies have been to try to reduce migration and reduce the amount of people showing up at our southern border. And part of our effort as in the United States and our government has been to destabilize prior trade routes, or prior, not trade routes, but immigration routes. And so you see on this picture of Mexico, the most common immigration routes. And basically, we contracted our neighbors in Mexico to try to destabilize some of those routes in order to make it harder to show up at our southern border. And as a result of that, migrating has become more treacherous, and people can't take the train the way they used to, which you see in the top right corner, and just kind of end up at the southern border. Instead, it's a much more clandestine route, which has led to more people paying for smugglers, and in the process, more people being abducted and victimized in various ways during transit. So as they get to our southern border, then we see that the asylum process has been severely diminished, to say it diplomatically, if not just completely attacked. And part of that has been, there's been a lot of different ways that our current administration has denigrated our asylum process. Some of them being through the transit ban, the safe third country policy, specifically trying to replace asylum officers who are a third party group that interviews and does credible fear interviews for our asylum seekers, trying to replace them with CBP officers to do the same job, even though there isn't the same level of objectivity. And then the other thing being that's been pretty impactful has been MPP, which is the Migrant Protection Protocols, which is sort of a misnomer, but it is the Remain in Mexico program. And so in 2019, we saw 59,000 people held up at the border as their asylum process is ongoing. And then 16,000 of those were children. 98% of those people are unable to obtain representation, which is important to understand. This is one of the main, benefits if you're trying to decrease immigration. The administration is trying to cause a deterrent or create a deterrent for people, or imperil this group's ability to obtain asylum and making them unable to achieve representation at the same rate as U.S. seeking asylum seekers is a very potent way to prevent them from actually getting asylum. And as we've seen and has been documented, there's also been a lot of violence on these folks as they've been waiting in Mexico because of COVID now, indefinite amounts of time. And we've seen, this is just over 7 months, how much people have kind of piled up at the different border sites where they're waiting for their asylum cases to be processed. And this has caused they think upwards of 10 to 20,000 folks to just go ahead and turn back and provide, which is deterring them, but obviously is not recognizing their legal international treaty right to seek asylum. Important to understand that a lot of this data comes from investigative journalism and reporting because there isn't epidemiologic data on this right now. This is one of the sites that reports a lot of this stuff. And then importantly, after this whole harrowing process of victimization in country along the way, and then again when they come to our southern border, important to understand how undocumented and not full citizen populations experience healthcare and experience kind of status in the United States. So they have baseline exclusion from a lot of the opportunities we are afforded as citizens. One of them being reduced economic opportunities, aka they are mostly dependent on the informal economy because of difficulties getting work visas, and because work visas are often not afforded to them for extended periods of time, but they have to continue applying for them. And so they're in the black market and they're subject to extortion and abuses by employers. Also, variations in access to healthcare, and that's due to Medicaid, obviously, and national health plans, and insurance does not cover folks that are undocumented. And also, the bottom line with that is just that they're still excluded from the ACA. And then on top of that, we have seen a rollout of expansion of the public charge rule, which specifically focuses and for all intents and purposes is a wealth test for these populations. And if they are applying for a green card or for naturalization or citizenship in the U.S., they get kind of a look back at their utilization of services. And if they ever used some of these services, they can be denied the opportunity to pursue citizenship or pursue adjusting their status. And the way this wealth test works is it applies if they have used certain things that are important for providing a social safety net for these populations. And that means food stamps or kind of different cash assistance or general assistance programs, and some of them being Medicaid. And the way this worked is the public charge rule initially rolled out as a very expansive extensive expansion of the public charge rule. And because of that, the news reports and everything were about all Medicaid was supposedly going to be under public charge, and that's what kind of went out in the news media. And then at the end of public comment, the actual public charge rule is kind of on a narrow spectrum. The only Medicaid population it applies for is people who are in long-term care facilities using Medicaid to pay for long-term care facilities. And so even though it doesn't cover it doesn't apply to a lot of these folks, there's still the idea that Medicaid could cause you to be a target for public charge and make you at risk of deportation. And unfortunately, that has caused already evidence. We've already seen people pulling away from what are good long-term, high-value ways of seeking care, like using Medicaid and using preventative care. And we know that because this has happened before every time we've enacted anti-immigrant policies in different states. You know, SB 1070 was one in Arizona that was basically allowing cops and different law enforcement to pull people over if they had a suspicion they were undocumented, which was basically racial profiling. And some of these, when that was enacted, we saw that women and their children got less prenatal visits and went to less of their prenatal visits. Similarly, in immigration enforcement legislation in Georgia, had this similar effect on a pediatric emergency department, and same thing when Prop 187 was enacted in California on mental health service use. And the important thing to understand is that the similar response is always that these folks make what is a very reasonable decision. They say, you know, I'm not going to go to preventative care because it might, you know, cause me to be in trouble for my status. And so I'll just wait till I'm actually sick. And, you know, when we look at the healthcare utilization data, we see that people have less visits and higher acuity as a result. And we're already seeing some of this since the Trump administration has come into office. Some of it has been undocumented mixed status families have been pulling away from Medicaid and specifically disenrolling from Medi-Cal and Medicaid nationally. And then we've also seen in these populations more preterm births due to stress and allostatic load. So summary of the instability. So folks are dealing with extenuating circumstances in terms of the reason for their flight and the victimization that's causing them to flee their home country. Then they're experiencing trauma in transit. Then kind of a arrival, initial phase of entry, they're further victimized and persecuted. And then during their stay in the U.S., we're making our national policies have been further threatening them and causing social, economic, and political exclusion. All right, and we'll stop sharing.
Okay, can you guys see my screen okay?
You're good.
Okay, so I wanted to talk a little bit about what are some of the actionable things that we can do in the emergency department to better treat this population of immigrants that we're seeing. So off the bat, one of the aspects of healthcare that's been very well studied over the years is the use of language interpretation. And specifically really that throughout all different specialties, training levels, and work environments, we're not really doing a good job at all of using them. I think generally the perception is that this is going to make us less efficient as providers and increase the length of stay. Some people believe it could increase the cost to the patient as well, but this isn't really the case. Limited English proficiency, it really strongly influences the healthcare experience of immigrants. It's been associated with lower satisfaction in care, decreased understanding of their medical problems, worse care received. That includes inappropriate tests, increased admissions, adverse medication reactions, not being able to follow treatment plans. And also in Hispanic populations, there have been studies showing that limited English proficiency is associated with decreased health screenings, vaccinations, and normal preventative care. It also affects kids too. Children of immigrants that are limited English proficient, including those in mixed documentation families, they also have worse health outcomes as well, including worse access to primary care, deferred treatments, including vaccinations, and delays in seeking needed care, like Todd had mentioned. Similar data is seen in elderly LEP patients as well too. Most importantly, language interpretation is the law. It first came into play with the Civil Rights Act of 1964, where it states that no person shall, on the grounds of race, color, or national origin, be excluded from participation in or be denied the health benefits of or be subjected to discrimination under any program or activity receiving federal assistance. So therefore, not using an interpreter and using ad hoc interpretation is kind of a form of national origin discrimination. The ACA under President Obama, Section 1557 specifically, went on further to mandate what qualified interpreters mean, specifically that they have to ensure client confidentiality, the language proficient. They also take into account cultural phrasing and vocabulary differences, which can be really important. Furthermore, it also restricts the use of minor children or adult family members as medical interpreters, unless the family member says so, or if there's an imminent threat to safety or welfare of that patient. And even with the recent ACA changes this past year, this provision was withheld regarding interpretation. So in terms of our practice daily and in our health system, using a certified healthcare interpreter in person is obviously the best, but there is data showing that video interpretation is very close second, followed by telephone. It's important to use interpreters that are credentialed to be interpreters, not ad hoc, and document the use of them. There was one study done recently that didn't find any difference in length of stay for patients who used a video interpreter, and the patients themselves were very satisfied with the quality of the interpreters, which kind of brings us to our second advocacy point as well too, is try to, in your healthcare system, advocate for having these resources. Another area where as medical providers we often miss out is having written materials in the appropriate language. Oftentimes I think we use things like Google Translate for discharge instructions, but a recent study at UCSF also showed that anywhere between 2 to 8% of Spanish and Chinese translations can have the potential to cause significant harm, meaning inappropriate prescriptions, inappropriate use of medications, and not understanding follow-up. So the discharge process especially is a vulnerable time, and language interpretation really should be used throughout the visit, not just during the initial evaluation. In our healthcare systems, we can advocate for having bilingual providers, ones that speak the language of the community that we're serving, and then also advocating for having more of these higher quality translational services, including video and in-person if possible. Lastly, I want to talk about safe spaces relating to what Todd and Shamsher had mentioned earlier. We're seeing some chilling effects where patients are afraid to access the healthcare system for all the reasons mentioned, including potentially being rounded up by ICE and deported. As the law stands currently, ICE cannot come into or set up outside of certain sensitive spaces, which include schools, universities, medical treatment facilities, including the ED and clinics, houses of worship, funerals, weddings, and public demonstration areas. That being said, there have been reports of ICE coming to clinics and hospitals, so this fear that some patients may have is totally reasonable. In terms of our responsibilities as a healthcare provider, we're not required to assist the agents unless the agent is presenting a valid judicial warrant or a court order. And really, your hospital administration should have a process for this, or you should advocate for one if there isn't. There should be an authorized person who can review a warrant if one is presented and make sure it's valid. In general, HIPAA prohibits the use of patient information being disclosed without that patient's consent, unless, again, there's a valid warrant. Something that you can also do in your healthcare system is making a Know Your Rights card. The one on the right here is one that we're using in Los Angeles County currently. It should be in the language of the patients you're serving. Have references to legal aid services on there, and let them know that the ED and hospital is a safe space for them to be and receive the care that they're entitled to get. Okay, and with that, I'll pass it on to Dennis.
Great, thank you, Hemang. So, hi everybody, my name is Dennis. I'm one of the other faculty at Harbor UCLA and part of the IDEO program. So, as Hemang and Todd have pointed out, with all the chilling effects from the recent rhetoric around immigration, a lot of people aren't accessing care. And I think getting a better understanding of what we can do for them when they do actually access care in the emergency department is really, really important, because we are often the only place where many people are accessing services. And as a frontline emergency department provider, you have an opportunity to really pick up on issues, educate patients about their rights, as Hemang pointed out with the cards, and really connect them to services that could potentially be life-changing and life-saving for them. So I wanted to start off with a case about a 21-year-old woman who you see in the emergency department at 3 in the morning. She's coming in, says post-sexual assault while walking home from her swing shift job. When you approach her about making a police report, you find that she's really hesitant, and she declines a work note because she wants to go home and go to work tomorrow. So in thinking about this, I think this case illustrates why immigration status plays such a big role and is a social determinant of health. Obviously, individuals who do not have immigration status often have fear and stress, as illustrated in this case, about any encounters with law enforcement or other perceived institutional structures, because they're afraid that they might be reported, put in detention, and at worst separated from their families, their children, their loved ones, and deported. At the same time, even though structurally individuals without proper immigration documentation are not supposed to work, as we've seen throughout the news from our president to individuals you may know, many individuals employ individuals who do not have the proper immigration status. In this way, the IRS has actually reported that individuals without proper immigration status pay over $23 billion with the B dollars in taxes every year, and those are 2015 numbers. So even though they aren't afforded the same rights in terms of employment protection or any of the benefits from taxes, they pay significantly into the system, much more than they cost the system, contrary to popular belief, and therefore they're especially disadvantaged and vulnerable. And obviously, without the employment protections of someone who has a social security number, this could lead to lots of financial instability, not only in the sense of poor access to benefits and the safety net when they are often in between jobs, but also challenges with getting employment that reflects the value that they can bring, because many of these individuals often work in a gray area or under the table. And when they lose their employment, they cannot get things such as unemployment, general relief, or TANF. Obviously, as Todd and Hemang have highlighted, this also leaves poor access to care. Not only are individuals limited in what sorts of health insurance and healthcare access they have because of their immigration status, there's also the chilling effect and the fear of accessing services, which leads to poor health outcomes. And why we often see individuals in the emergency department coming in for the first time, and we are the ones diagnosing their stage 4 cancer or their DKA. And that's something that theoretically should never happen in a country that is as wealthy and as well resourced as ours. And so in terms of general phrasing, how can you approach a patient? I think we're going to go over specific examples of how patients can be eligible for immigration relief. But I think as a general script, you can customize as you learn and remember more about the programs. Our suggestion is sort of having something very general in terms of educating patients that you suspect may be eligible for some sort of immigration relief and services, that they're actually eligible for some change in status, and then definitely referring them to an immigration lawyer or one of the other resources, because this is a very complex area of law that is easy to mess up, and the stakes are obviously very, very high. So different types of immigration relief that are available. I think generally in this sense, I think keeping these slides as a reference that you can pull up would be very helpful. But the framework for thinking about this is thinking about individuals who are victims of different types of crime. That is one large category that makes them eligible for immigration relief. So the U visa is for individuals who are victims of or witnesses to crimes, serious crimes such as violent crimes, shootings, stabbings, vehicular homicide, rape, sexual assault, things along those lines. And as long as they're willing to file a police report and cooperate with law enforcement, they are eligible for adjusting their status. I think as many of us work in trauma centers or in the emergency department, we often encounter these victims, and I think there's a large missed opportunity. The second one is a more specific category. It's focused specifically on individuals who are victims of intimate partner violence. But I don't think you need to remember the specifics. You just have to remember any sort of serious violent crime will make an individual eligible for immigration relief if they're undocumented and as long as they're willing to cooperate. The T visa is slightly different. It's sort of related, but it's also other sorts of serious things. And for the T visa specifically, it's for individuals, T for trafficking, who are victims of trafficking. And often we see this in terms of human or sexual trafficking, as well as labor trafficking. So if you pick up on this, I know there's a whole body of work that's out there in terms of picking up on individuals who are being victimized and sex trafficked and labor trafficked. But just keeping in mind that if you do identify an individual and immigration is a concern, there is relief available for them. Other special categories are sort of what one might expect to be vulnerable populations who don't have good ways of getting back safely to where they came from. This includes juveniles who are abused, abandoned, or neglected by their parents, individuals who are asylees, who are present in the country and who don't feel safe going back to their country, and individuals who are in this country who can't go back to their country because their home country is undergoing a civil war or other types of unrest. So once again, I think just keeping in mind these large categories and then using a general phrasing or more specific phrasing as you prefer and getting people to immigration attorneys is very, very important as an emergency department provider. And in terms of resources, the IMMI.org website is a nonprofit website that actually does a really good job in the absence of an attorney of walking people through potential options. Obviously, it's not a substitute for an attorney, but obviously in the middle of the night, it can go a really long way to help patients discover and think through what types of relief they may be eligible for, after which they can contact an attorney. And in terms of attorneys, a word of caution. Just like many other professions, there are a wide range of attorneys, and there's always small groups who may be unethical or be predatory. So generally, we recommend reaching out to nonprofit providers who either charge nothing or very low cost for vulnerable individuals such as these. And I've listed 3 websites that list a large number, not complete number, of nonprofit organizations that may be a good starting point, that are trusted and reputable. And even if they may not specifically be able to help the individual, they can often refer them to an organization that is trustworthy. And finally, there's something called a medical legal partnership that brings some of these nonprofit, free or low-cost attorneys into the healthcare setting to work with the rest of the healthcare team, just like how we have social workers or case managers in our emergency departments. One can also get lawyers into the emergency department. And you might ask why you need a lawyer instead of a social worker. And a lawyer can obviously help with very specific things and allow everybody to work at the top of their license. For example, when we're talking housing, an individual who is homeless, experiencing homelessness and needs help with housing can get help from a social worker in terms of a list of shelters, applying to different programs, whereas an attorney can help do housing preservation if someone's about to be evicted. Similarly, in the immigration context, if someone needs help adjusting their status, a social worker could refer someone to resources, provide emotional support, and do a lot of very important work around stabilizing them in terms of financial resources and other resources. However, the social worker cannot necessarily feel comfortable and want to help someone adjust their status, and that's where the attorney is very valuable. And, just to, I think, drive this home, I think all of you get it by now, why adjusting status is important. Obviously, we've talked a lot about immigration as a social and structural determinant of health, but I think the big things that having status allows is it allows individuals to be on equal footing and be eligible for employment in a proper way. They're eligible for benefits, and they're offered the full protection of the law without fear of retaliation in terms of deportation or detention. And just a word of caution as I wrap up in terms of notarios. These are individuals often present in different communities, including Southern California, who hold themselves out as experts in different areas of the law. And as you've probably realized, if you've ever had any difficulties or encounters with the law, the legal process is quite complicated, and that carries over to immigration. And so the notarios are notorious for missing deadlines, for screwing things up, and taking advantage of the clients and charging them a large fee, with the end result of either deportation, detention, or other adverse outcomes. So really making sure that you as an advocate get patients to a trusted provider is key, because otherwise they may end up somewhere where the individual helping them may be causing them more harm than good. And with that, I'll turn it over to Dr. Janeway to bring us home.
Okay. Can you guys see my slides?
Yes.
So I'm going to go into a different segment of our talk and move a little bit beyond the more pragmatic in-hospital solidarity that we are able to provide as physicians specifically, and move into the idea of how we can engage as healthcare professionals in a more liberatory solidarity. And this involves concepts that you may or may not have heard of, including border abolition, and really thinking about how the larger structures are at play in the world and how they create systems that are unfairly oppressive to certain groups of people. So many times activists and scholars, including physicians, kind of constrain solidarity to the parameters of traditional moral and political theory, which really prevents us from being able to truly engage and create change and liberation. One of the people who have spoken a lot about pragmatic solidarity is Paul Farmer, who you guys all know. And he talks about a lot about the response to structural violence through kind of rapid deployment of tools and resources to those who suffer from violence. And I'm not trying to downplay the importance of that, of relieving suffering when there's great harm being done to specific individuals. In fact, I'm sitting in Tijuana right now working with refugees and asylum seekers at the border, and I'm doing exactly that, a very pragmatic form of solidarity. But I think we also have to recognize how it fails to call into question kind of the larger infrastructure that allows the deployment of services to go to specific things, or allows us to prevents us from declaring a more upstream goal beyond proximal suffering. And in failing to do so, it kind of risks creating what we've talked about as like a raft of humanism and compassion that kind of only expands to the providers who are providing the care and to the select few that we are in solidarity with. And this kind of ends up creating an ultimately futile process in creating true change. So instead, we're trying to move beyond that to a different lens of liberatory solidarity that is both pragmatic, but also firmly anchored in a more border abolitionist agenda. And this advancement of border abolition, kind of like the advancement of prison abolition, has been proven to be successful in many different areas of political change. So the following slides are kind of going to discuss this more liberatory solidarity approach to immigration and migration, and move away from the idea that we are just allies to the realm of really trying to be accomplices to the communities that are struggling for this. So as I mentioned, we really need to broaden our framework and move beyond this thought that there are just these people who are moving from violence or from economic struggles that are moving across borders, and that they're in two different groups of people and somehow distinct. And we need to recognize that, one, people have the right to move, and two, that people have the right to stay. And embracing this right to movement requires us to recognize a historic origin of national borders and reject their role in dividing and controlling populations. And this is particularly important when you're thinking about the capitalist system, because there's a contradiction between the ability to freely trade goods while rendering human bodies illegal to pass across borders. And equally important and related to global capitalism is a rejection of the displacement of people and the rights of individuals to stay where they want to. So approximately 1% of the world's population are considered displaced people. And this really shouldn't be taken lightly, because that's also tied to these social, economic, and psychological sexual violence and mental health sequelae of forced migration from many different areas of the world. So humanitarian interventions that solely mitigate the downstream harms of displacement, kind of like what I'm doing, without addressing the upstream causes of this displacement, are ultimately going to be inadequate in creating change that's lasting. So what do we do then? How do we really engage with these principles and move towards a form of liberatory solidarity? And I think there's a few different things that we can do. I think the first is we can partner with community organizations. So those can be community-based organizations in the United States, and they can also be transnational organizations or community-based organizations in areas where migrants are coming from. So here you can see I have two photos. The first is actually from a action that was done by people in Tucson, Arizona, where they chained themselves to the front wheels of deportation buses and gates at the federal courthouse, alongside of activists who were undocumented immigrants and other people in the community, in order to try to press change. And on the right, you have the Black Panthers in their acupuncture clinic that was started during the Black Panther struggle for civil rights in the 1960s. And so by partnering with these organizations, we are allowed to engage in with more the infrastructural determinants of health, because we're engaging with our patients and their struggles more directly. In doing so, it also forces us to kind of reevaluate the idea that there is a natural hierarchy to medicine, and really try to put the provision of health where possible back into the hands of the community and support them in solidarity with having radical actions like, placing health clinics in day laborer spots, or engaging with ICE in their very punitive detention practices. It also means that we need to realize that we need to be better about doing more strategic organizing with the community. In medicine, we're often taught that we only have a few tools in our toolkit in terms of creating change. You can write a perspective piece or an op-ed, or you can work very formally with the health system to through all these fancy committees to create change. And I really want to argue against that idea. As physicians, we actually have a much broader toolkit that we can use. And generally, because physicians occupy a place of privilege in society, we can use that privilege to partner with the community to create change in many different ways. Yes, sometimes that includes op-ed or a petition. For instance, in Los Angeles, there was a petition that really changed a huge amount of funding that was going to create a new jail. And instead, that money is going to go to creating more mental health services and really investing in the community. So that is an example where just a petition was done and then that changed it. But what you have to understand about that petition is that that was resting on the back of 10 years of community activism and other strategic risk-taking that was being done by the community. And only when the petition actually came and physicians started to lend their voices more broadly, did that actually be able to take effect. So really, though, we should be engaging with the community when these movements starts, because in some ways, given our position of privilege, we can sometimes accelerate them. And so that's recognizing that you can use protests strategically, You can work with community organizations to prioritize what they feel is important and stand with them as accomplices instead of just allies in their struggles for liberation. And providers should also recognize their complicity with and challenge the global infrastructure that drives displacement. So that's, the capitalist system that is free trade practices and oppressive domestic policies that support military interventions and other neoliberal reforms and structural adjustment programs. So here are some organizations that have done a lot of transnational work. For instance, Physicians for Social Responsibility, countered nuclear arms proliferation, and kind of created a model for how healthcare providers can use a health framework to influence contentious geopolitical debates. You have organizations such as CISPES, which is the people of El Salvador, Solidarity with the People of El Salvador, which is a transnational organization that was grounded in a local grassroots movement that kind of created opportunities for collective consciousness and resistance against this global infrastructure. And this is really imperative to achieve this infrastructural change, particularly when it comes to border activism, because border activism is so grounded in the fact that, of those relationships across and between borders. And lastly, this is just to kind of reinforce the idea that providers have to acknowledge, in order to create real liberatory solidarity, their privileged role in societies in which we have, having medical degrees, are given more of a voice and seen more as moral authorities. So these pictures I'm putting up on the left is a group of lawyers who recently were arrested alongside of a group of undocumented immigrants as well, who all sat together and chained themselves out of the governor's office in order to call for the release of everyone in ICE detention during the pandemic. And so these are kind of like this is kind of being an accomplice with these undocumented immigrants who are indeed taking much more of a risk than the lawyers themselves. And on the right is an action that was done by a group of physicians trying to vaccinate migrants in detention, a CBT detention facility, where they got arrested as a way to try to force media attention and change on the practices that were being done in CBP detention. And I think we need to realize what our role could be in really bringing attention to this unfair dynamic that's created, whereby people on one side of the border are offered certain services and people on the other side of the border are not. And really question this idea that migrants are any different from any of us and really different from one another. Migration has been created by these larger infrastructural issues through the way that we have prioritized basically capital over people, and how we are going to challenge that is going to require an approach that is much broader and is much more liberatory in its effect. So I think that brings our talk to the end. I don't know if any of the other speakers wanted to add anything to my final thoughts, but I really hope that when you're thinking of immigration and you see an individual patient sitting in front of you, it's not just that patient who's sitting there and it is an immigrant. Certainly you can help them in all the ways that were discussed in this lecture, things that really can reduce their suffering and increase their access to both medical care, legal services, and improve their individual lives. But realize that without taking a more broad focus, you're never going to challenge the processes by which those people face oppression to begin with. Thank you.